And I think it's actually working. Yes, indeed. Good afternoon or good evening, America. I am Dr. Randy Fink, and this is Fertility with Fink and Friends. I am Fink. You are friends, and here we are at 4 o'clock p.m. Mountain Time, which means 6 o'clock on the East Coast and 3 on the West, 5 o'clock in Zona Central. And we have a very special program tonight, live from the American Society for Reproductive Medicine annual conference in Denver, Colorado. So I am the clinician at CNY Fertility in Colorado, and joining me tonight are three very special guests, people whom you may know. Certainly you know this handsome fellow. This is Robert Kiltz, our fearless leader from Syracuse, and also joining us in the house tonight, Dr. Edward Ditkoff from CNY Fertility in Albany. And lastly, not lastly, as importantly, Dr. Eric Chang from CNY Fertility in Buffalo. Hey, thanks so much for being here tonight. As always, this is our favorite place to be. It is my favorite time of the week to be here. The time that we can all get together and talk about the things that are most important to us, and that's the things about making a family. And that's what we're here to do. And so we like to answer lots of questions. I see there's a whole bunch of questions coming in. We're going to do our format a little differently tonight than we normally do on Fink and Friends, just because I can't really get close enough to the screen to say hello to all the people whom I usually say hi to. But we've got a couple of different Instagram feeds. We've got mine at Randy Fink MD. We've got CNY Fertility, and we've got YouTube, LinkedIn, and Facebook here as well. So since I can't see the names of all my friends who are joining, let me just say hi to everybody, and thanks as always for being here on your Tuesday evening and spending this time with us. I do see questions coming in, and we will get to that, but I want to just ask my colleagues here. So this conference, the American Society for Reproductive Medicine, is a yearly convention of those in reproductive endocrinology and infertility, where we get together and we can talk about things that are up and coming in our science, new data, new research, and really the opportunity to kind of learn new things. What have you learned this week?
Well, the most important thing that I've learned is that it's the connections with our colleagues that we're learning by meeting them one by one. And we all have an amazing story to share, that we're here to help those suffering from infertility, from miscarriage, and so many other reproductive disorders. So it's really the connections with each other and from our colleagues around the globe. What are you doing? What are you finding? What can we all do to bring this together and make it more accessible and affordable, and integrating Eastern and Western practices along with standard science, which I think is good, but something more important is about the connections with people.
Yeah, I agree. I think that's probably one of the most critical things that we can do in a place like this, is talk about really what our best practices and how we can pull it all together for folks. Dr. DeComp, what do you think?
Well, I think I've seen a lot of interesting discussions, heard a lot of discussions, took part in them regarding patients with uterine scarring, and repair that using stem cells in the future, stem cells correcting the DNA in sperm and eggs, discussions of various frozen protocols to help patients who may have difficulty with one particular protocol and the rationale for using one versus another. I think it's a very good meeting, very interesting. I agree completely with what Dr. Kill said. It's very important to speak to our colleagues one-on-one, because then you have these unique discussions that aren't happening in the big discussions. So it's really a very good conference to go to. I'm very happy with it.
Well, you may also be hearing the ambient noise from downtown Denver. And normally when we do these programs, we do them in nice, quiet places without the distractions of a big city. But here we are in a hotel in downtown Denver, and that's why it looks a little different, and it probably certainly sounds different. So hopefully you can bear with us and learn a little something from what we've learned here. Dr. Chang, what's been the highlight of your week?
Well, I think that when you get people from all over the country to come together, different doctors from different areas, it actually really is helpful for us at CNY because CNY is such a big practice and we take care of patients all over the country from all sorts of walks of life. So I think that getting a perspective on how to do fertility medicine in the Northeast versus in the Southwest, there are different idiosyncrasies there, different patient populations. It's been very interesting, very nice.
Well, and since you say that, one of the things that I think is most unique about what we're able to do is that, so this guy is in Buffalo, this guy is in Albany, this guy is in Syracuse and Sarasota, but yet we're really practicing the same way, that we bring the same set of ideals and values to the practice we have. So, there are a lot of similarities in what we do, but there's also lots of differences, and that's really kind of what we're here to learn about. Well, I have to ask before we dive into questions, how many people, Dr. Kiltz, have you been able to convince that carnivore is the only way to go? In the last, let's say,
as Dr. Hill said, if inflammation from endometriosis is going to have an adverse effect, it only makes perfect sense to remove it prior to that critical time where a patient could be getting pregnant.
Let me just add one other thing, that I think that the inflammation from endometriosis is secondary to gastrointestinal or bowel infection. And so we don't talk enough about the infections in the bowels and in the pelvis, which may be amenable to a use of an antibiotic protocol. We know that gastric ulcers are treated now with antibiotics for 30 days.
Sure.
And I've been recommending a levaquin flagyl valtrex diflucan protocol for 30 days. I think that's something we need to be starting looking at much more, because inflammation and infection are related. And so I've seen a lot of people improve. We just don't have the data supporting yet, but we're not waiting for data, because you need to be treated with something. And I think that's one of the things that we've done at CNY Fertility.
Sure.
We've come up with thoughts and ideas how to improve all this for everyone.
Well, to that point, actually, I'll mention also that there has been a lot of talk here at this conference about both the uterine, the vaginal, and the gut microbiome, which means the environment in which all the bacteria live, and how that stuff may really play a big role in how the body responds both to disease and to just normal life. There was a question I saw over here. Any plans or thoughts about bringing a reproductive immunologist into CNY?
Well, we are reproductive immunologists. That's what we do. And ultimately, I've been studying reproductive immunology for 30 years. And so it really is, there is no fellowship or special training. We learn by practicing that, and we've been doing it for 30 years. So we practice reproductive immunology. Ultimately, we are that. And the diagnosis is really disease. If we need to talk more about the diagnostic testing and looking at inflammatory markers more, and we'll be glad to do that more for you. But really, again, that is what we do already.
Well, I'm going to throw this one over to Dr. Chang, and this comes from Caitlin. And Caitlin got some great news. She says she had an ultrasound yesterday. She's 6 weeks today. They saw a gestational sac with a yolk sac, and maybe you can explain to us what that means. But also saw a second smaller gestational sac, but no yolk sac inside. What could that mean?
It's interesting. Well, we have to ask her how many embryos did we actually transfer with that? Okay, so
We can't get that answer right now.
oh, yeah, that's right now.
It's a one-way conversation here, kind of, right?
But certainly, if we had transferred 2 embryos, there's a possibility that we could have a multiple gestation situation.
But one embryo can still divide and become 2, can it?
Sure, absolutely, absolutely.
How does that happen?
Well, the embryo, if we transfer a singleton embryo, it can still divide after the transfer, of course. And, that's certainly a possibility, but we are usually trying to attain this kind of result.
Well, what is a vanishing twin? What does that mean?
A vanishing twin? Well, you can have a pregnancy that, you can have an embryo that implants and then gets to a certain size, and then perhaps, it's not, not genetically competent, and then could, disappear later.
Well, the good news is she's got a yolk sac in the first one, right?
Right.
Which means that one looks like it's headed right where it's
High
supposed to be. Yeah, that's very good. Next thing we would want to see there is that heartbeat. And once we look and see that heartbeat, we know that 95 or more % of those pregnancies will continue on. And that other sac, as he said, it may be a second pregnancy that maybe that embryo divided, or maybe we put in 2 embryos, not so sure based on your history there. But so they'll be following that one to see, does it grow or maybe does it regress? But meanwhile, fingers crossed, Caitlin, that is very excellent news. And we are all jumping up and down. Don't jump up and down, please, because I think there's the law may get involved with that. Okay, we do have some folks here on Facebook. Thanks and hi to Olivia. Olivia asks, what would be the best protocol for tubes tied, but a slight touch of PCOS. My first transfer was unsuccessful. Now, Olivia, you said your transfer failed, and I don't like to say failure because every time we do something, we always learn about that process. So we always get something from it. So the first transfer wasn't successful. You have two kids naturally, and you were wondering what could have caused the transfer not to work. So it sounds like you got a couple of questions there. Best protocol, I presume you mean for embryo transfer, since you already have embryos. You had a tubal, a little bit of PCOS. So we'll talk a little about PCOS here, I think, and then what causes a transfer not to work. Um, as far as PCOS goes, Dr. Dickoff, what percentage of do you differentiate between polycystic ovarian syndrome and ovaries that just behave like polycystic ovaries?
Yes, I do. In some regards, it all depends on what the endpoint is. If women have regular ovulatory cycles in their ovaries, PCOS, for example, very good ovarian reserve, that's one thing that we need to consider. On the other hand, if someone has ovaries that look PCOS, but they're not ovulating regularly, they will be treated differently. So it really depends upon what the patient's treatment plan would be and as well as their diagnosis.
Well, let's talk about a little controversy here because this is something that may differ between us and some of the docs at CNY. There is a medication that we often use in the fertility world for folks who have polycystic ovaries, both in the retrieval aspect and at the time of embryo transfer. What's your feeling about metformin for a patient who is undergoing transfer?
Okay, well, metformin is an interesting drug that was brought up. I know there's a lot of different thought process about it. If you do one main understanding or agreement is if someone has elevated hemoglobin A1C, it is definitely indicated. If someone does not, there are potential benefits of metformin, such as the anti-aging effect, and it could help the metabolism. It could help a patient lose weight if they're have excessive body weight.
Which is going to enhance the fertility as well.
Correct. So there's a lot of reasons to consider metformin. And to be fair, in a one-ended conversation, I don't want to say something that I may regret.
Can I
By playing it safe.
Well, I think there was an open-ended question, and metformin kind of narrowed it a little. I think the important thing, I was kind of listening to what you were saying, and to answer your question, I have other things I could add regarding frozen transfer protocol, frozen protocol cycle with someone with PCOS or not, but we could go on.
Well, can we just, it's a little more about PCOS? Polycystic ovarian syndrome is essentially a plant-caused ovarian disease because it's metabolic disorder, it's pre-diabetes, diabetes. So there's a spectrum of pre-diabetes. Likely most of us have a pre-diabetic condition because we eat a lot of plants, which break down the sugar. We eat low fat, which is our biggest problem, which I don't think we're really talking about. That's why keto and carnivore are so critical. Metformin, I think its main function, it makes a lot of people like not want to eat because it causes a lot of gastrointestinal dysfunction, which actually means they're eating less and or they're absorbing less. So their glucose and sugars levels drop. And so they tend to get less glycation or damage to their ovaries and their hypothalamus pituitary and all the other products that affect fertility. I personally don't think obesity causes disease because I think it's the plants that cause the damage, which also happens to make the fat, which is getting us ready for famine and gestation and things like that. So I'm not a big fan of metformin personally, but I think it helps a lot of people. And maybe we could just add something on the GLP-1s.
It's very important. You know, the GLP-1s are the Ozempics, the semaglutide, the Mounjaro, these drugs that are very commonly being used for weight loss now. But the party line is you're not supposed to be on that if you want to get pregnant within 2 months. What do you think is going to happen with those guidelines?
Well, I think that losing weight is hard, and I don't think the losing weight is critical in this. But I think metformin and GLP-1s help because they cause a lot of gastrointestinal dysfunction, your appetite's suppressed, and this does the same thing. It lowers your intake of food, which ultimately reduces your glucose levels, glycation is reduced, and feel better, and many people will get pregnant on these drugs. We don't generally recommend GLP-1s when you get pregnant, but I'm betting we're going to find a lot of information that probably is not as harmful as we think it is, because many women are getting pregnant on them.
Right.
But once again, early on, but this drug's been around for a long time. We're not recommending them if you're in the process of getting pregnant, but preparing, there may be some benefits. Now, I personally believe that keto and carnivore diets are a better way to go, and fasting, but you know, if it's not working that way, then using these may be important for you because it's hard to do these diets.
Sure. Let me just answer real quick here. This question, how do I know if I have polycystic ovaries? How do I know if I have polycystic ovarian syndrome? So a couple of different things there.
Well, that's a clinical diagnosis, in my opinion, which can be confirmed for a lot of patients with objective labs. For example, if someone has regular ovulatory cycles, I don't think that fits the description of clinical polycystic ovaries.
So what's the classic syndrome of polycystic
Okay,
ovaries?
well, not to be too technical, but there's different ways of diagnosing it. But number one, irregular cycles.
Okay,
Number two, you could have hirsutism or excess body hair.
hair.
Number three, unfortunately, prediabetes is part of it, as Dr. Kilson correctly pointed out.
Metabolic syndrome.
It's a metabolic problem. It does involve, hemoglobin A1C, which is where we talked about metformin being accepted if there's elevated hemoglobin A1C. They could be overweight, but not necessarily. There's a lot of women with polycystic ovary disease that are very thin. It's not related to weight. It's more insulin.
So, I mean, the bottom line, it's difficult to diagnose as well.
If you have polycystic ovaries, so you have polycystic ovaries. But
You can
the
see
syndrome,
something on ultrasound. Ultrasound may look, it has a classic appearance on an ultrasound, looks like a chain of pearls. And those are a bunch of little follicles in the ovaries that are not being released. There's also something with in the blood. There's some blood tests that we can do that look at androgen levels, male hormone levels. And sometimes we can even tell in the AMH level, your anti-Mullerian hormone, because that suggests to us how your ovary is going to respond
If it's
to
elevated.
treatment, if it's elevated.
so
Yeah.
over 5 may be more of an indication
Yeah,
of
yeah.
PCOS, metabolic syndrome, prediabetes. But the problem is there's such a gray zone because people want, like, I either have it or I don't. But in fact, if you're not getting pregnant naturally, even if you have regular cycles, and you may look at the ovaries and believe there's some PCOS looking ovaries, we may call you that, but in fact, probably
Don't have it.
but whether you label you have it or not, if you're not getting pregnant naturally, it's likely some inflammatory or metabolic disorder that we're missing completely.
Indeed. Let's go to the second part of that question. I want to ask Dr. Cheng, how do you counsel a patient? Let's say someone has on your schedule, she had an embryo transfer and it didn't work, and she wants to know what happened. Where do you start with that?
Well, we have to look at the clinical scenario. We have to see if she has any of these things that we were talking about earlier, endometriosis, PCOS, whether she does have a elevated hemoglobin A1C or she has hypertension. We have to start there and see if there's some identifiable cause that we can treat that might decrease the chance of implantation.
Does IVF work every time?
Oh, absolutely not. Yeah.
So, but we have this idea that we're going into this, we're spending money on it, we're expending energy, not just financial capital, but emotional capital to do this treatment, and there's an expectation that it works. How do you talk to people about realistic expectations?
Patients have to understand that, especially if an embryo is not tested, a patient that's not advanced age, so not over 35 years old, even in the best case scenario, has a blastocyst or day 5 embryo, high quality, the pregnancy rate is only going to be, perhaps 65%, 70%. So,
Which is not 100, right?
It's definitely not 100%.
Yeah,
Yeah.
indeed. I see my friend Ruzik Blue from Las Vegas is here, and Ruzik said, if I've never been pregnant, never had an implantation after 6 embryo transfers, and have done all of the tests except for Emma Allison receptiva, and this has been a topic of controversy. what would you suggest? See, it's contradictory. Ladies and gentlemen, Edward.
I inherited this one. What I would suggest is, first of all, if the patient hasn't done that test and they would feel more comfortable doing that test, I think it's worth doing if it's going to help the patient get through this process. We could, it's one thing to say things, it's another thing to know things. Data does have a benefit. So, we could.
But, so this patient is a CMY patient. So therefore, she's come through and done 6 transfers and had some immunologic treatments by us too, just by default.
Okay, what I don't know is, I don't know how old this patient is. I don't know if these were PGT embryos. There's a lot of things I don't know to factor into that.
Well, let's ask it this way. So, there was a time that tests like, that some practices were saying, we want to do Emma and Allison and ERA on every patient before they ever have a transfer. And what we have learned is that those tests are not as valuable as we once thought they were. In fact, there's a lot of studies that have shown.
Maybe only 10% of the population you would find something on a receptivity test.
And it may
Not a high yield test.
may not be a high yield test, but after having six transfers without success, is there a place for these tests that may have otherwise been debunked?
Okay, again, I don't know what stage these embryos were. I don't know, high quality, low quality, and what the age.
10,000-foot view.
10,000.
Well, non-implantation may be caused by environment, of uterine environment, or by quality of the egg and the sperm and the embryo. So they're two kind of very different categories.
So let's assume it's a good embryo, because we can't change the embryo.
Right.
Okay? And every embryo has the right to be in a uterus to give a chance.
But when you can, will a good diet actually change the quality of the eggs being produced?
Oh, absolutely. So egg and sperm can be improved by nutrition, lifestyle. I think carnivore. I think laparoscopy, seroscopy is, I think, important, and/or empiric treatment for 2 months with either Lupron or Myfembree or Alyssa, with I think 30 days of antibiotic and fungal antiviral. Again, inflammation is the cause, and the endometrial scratch hysteroscopy may help kind of rough up the endometrial lining,
Get the blood vessels to grow in.
cause some local inflammation, which may help with implantation. So in fact, the ERA receptiva eminalis may not give us the information that's going to change anything, but in fact, the DNC or the biopsy, because we know many women have a miscarriage or a DNC and then get pregnant afterwards. So those are some things that I think, if you realize that inflammation is critical to prevent pregnancy and actually to prevent pregnancy. Without it, there must be stickiness for that embryo in the uterine lining.
Sometimes we want to suppress the immune system, sometimes we want to boost it.
Right. But we throw mud at things. It's kind of like a shotgun approach. We'd like to fine tune it a little bit, and I think people want this information sometimes. Whether or not it answers the question, they say, "Hey, listen, I would like to do the Alice receptiva ERA," and to say, "Well, it doesn't work." Maybe the problem is it doesn't work on the masses, but there might be some unique cases that it does. Just like some people are allergic to peanuts and some people are not. We just don't know who it is.
There's also different protocols that we could use, and even though there were 6 cycles, I don't know what those protocols were, and there's different approaches. Sometimes we could use minimal stimulation for frozen transfer. Sometimes we could do a natural ovulatory cycle. There's different types of natural ovulatory cycles. There's modified, there's unmodified.
Any variation.
Right.
So many different ways of trying things.
Well, and Dr. Ditkoff and I were talking earlier today that in many ways, a natural or a letrozole cycle with a trigger shot may be very helpful, because sometimes we give you too much stuff.
Yeah.
And too much is stressful emotionally, physically, and less is best. But I think we always have to look back at, okay, what's everything? Are you doing yoga, meditation, acupuncture? Is your mindset thinking, I'm a mom, I'm a dad, we're parents? To start with, those sort of things can be helpful, reduces stress and inflammation. But then the pharmacologic treatments, IVIG, Humira, we don't have lipids, but Humira and IVIG are things that we don't talk about enough. And those probably are something we should be looking at more when we say they're too expensive, but IVF is expensive. And so we have to take our biases out of that and think about that. Now, it may warrant doing a full immunologic panel that gives you some information. You say like, okay, I feel better. I've got some knowledge, even though our science is still arguing whether or not it gives us the actual answer.
Hey, it's a little after half past the hour. We're going to be here for about another 30 minutes. I'm Dr. Randy Fink, and this is Fertility with Fink and Friends. I am Fink. These are friends, and so are you. I've got Dr. Kiltz, Dr. Dickoff, and Dr. Chang here, all from various CNY fertility places. And let's see if we can get some more questions in here in the next half hour. We're live from Denver, Colorado at the American Society for Reproductive Medicine's annual conference, where we actually get to be together in a room. And I have to tell you, it's very special. It's a very special time indeed. Here's a question for you. This comes from Key Knows Better. Is a fresh or frozen transfer? What are your feelings about fresh versus frozen? She has diminished ovarian reserve. She has blocked tubes, and she retrieved. And for diminished ovarian reserve, I'm just going to say you did pretty well there. 25 eggs retrieved. So I wonder where you got that diagnosis. Yeah, but and tomorrow, I guess that was today, because tomorrow you'll find out how many were fertilized. But so now you're thinking about fresh versus frozen transfer. There may be a real peculiarity in your situation there with 25 eggs that might mean a fresh transfer may not be the best bet. What do you think?
Well, I would take a look as well at the parameters regarding transfer, what our estrogen levels were. We want, of course, always be safe, and we want to reduce the risk of what we call ovarian hyperstimulation.
And so does that correlate with the number of eggs retrieved?
It does, but it's not all one size fits all. In general, if a patient has over 20 eggs retrieved, I like to look at the situation and think about that, especially look at the other parameters and see if she's at risk or not.
Dr. D, what do you think about fresh versus frozen just across the board?
Well, there's no one perfect answer for everybody. That's number one. I have guidelines. I do suggest to patients what I think based upon their situation. But I don't want anyone to think this is absolute, because there is no thing that's absolute.
There's no absolute, right?
I was going to say, if someone wants guidelines, what I could say is if they produce more than 15 eggs, that's one reason to consider not doing a fresh transfer, although I've seen many women produce more than 15 eggs that get pregnant with a fresh transfer. But I think the literature would support encouraging somebody to do a frozen if they make more than 15 eggs. As far as progesterone levels, although there is controversial data out there, again, nothing is definite, but a lot of people will say if the progesterone is greater than 1.5 at the time of the trigger shot, they should consider a frozen transfer. If the patient's at risk for hyperstimulation, what if the patient has like AMH of 10, 15, and they're feeling bloated and lousy, getting into retrieval, I think that they should be considering a frozen transfer. I think the lining too. You have to look at the uterine lining.
If you see fluid there already at the
Fluid.
there's a lot of fluid there already.
Well,
The fluid in the cervix doesn't matter.
No, in the belly I'm talking about.
Oh, yeah, a little bit of fluid in the belly is not an indication not to do transfer. And elevated progesterone, I'm a trigger, I think it's important. I go up to 2. When people come to us from all over the country and the world, they can have a fresh transfer if that's what they want. But ultimately, our frozen transfers that we've looked at all of our numbers are better than fresh across the board. And so we, in general, recommend frozens over fresh. The reasons to not, because of your risk of hyperstimulation and of failure, but ultimately they're not our embryos, they're your embryos. And we want to give you the ability to say what you want. We're going to give you our recommendations, but we're not going to force you to do one way or another. So that's one thing important at CNY. But you're here, and we're here to improve your odds. But the numbers, and we looked at all of our numbers, frozens are overall better than fresh. Whether it's day 3 or blasts, the data at CNY has supported the frozen transfers.
And that goes against what a lot of people may think, just coming outside the box. Well, fresh vegetables are better than frozen vegetables, so a fresh transfer must be better than a frozen transfer.
All
But there's
vegetables are deadly.
You heard that?
Yeah.
Tell me about this. The industry has, and when I say industry, I mean the practice of infertility has gone through a series of changes over the years. Because for a time, every transfer was fresh, was it not? And then it went to frozen, and then now it's coming back to fresh with these possibilities. It has come.
True, it's come
in
back
waves, right?
and forth.
Yes, there have been different medications that have been related to that. For example, years ago, everybody got HCG for triple shot. Now we give less HCG, we give more Leuprolide. And a lot of people would think that because of that, it's good reason to not to do less fresh transfers, which goes along with what you're suggesting.
And there's different disease states too. So patients that have PCO or endometriosis, pregnancy rates may not be quite as good with a fresh as well. So there's some data, it's not very good data, but you know.
Well, like what you said, if you want a fresh transfer, we want you to have a fresh.
We ultimately try to,
Really
try to enable that for you. but-
Yeah, and what I found is if you have more follicles, more eggs, as long as your estrogen level is lower, and your progesterone level is lower, and your lining is 7 millimeters at trigger or better. Because we've never shown that a lining at retrieval matters, it's at trigger. But our job is to give you our opinions and help you make the decision in all of that.
I do see Mrs. Keybell, who is here most of our Tuesdays, has beta day tomorrow, so all four of us have fingers crossed here for you. There we go.
I
And
have-
that's for everybody
I
who has
give you
betas
this.
coming up. Yes?
I'm visualizing a baby.
All right. Love to hear that. Bryn, it looks like Bryn is asking, why is birth control sometimes used before a transfer?
Well, I think it depends on what patient we're working with. For example, let's say you have a patient and has irregular cycle, she has a thick uterine lining, and she wants to start a cycle. There's a lot of ways of giving a hormonal treatment. Birth control is one of them, which is easy, because you just take one tablet for several days, you get a nice full period, and you're ready to go. So that's one reason. It could be programming the cycle for the patient's schedule. What if the patient wants to go on special vacation and you want to delay the period? You might want to use the pill for that. So there's a lot of different reasons to use hormonal medications or birth control pill to program to make a schedule more convenient for the patient. Medically speaking, I don't know if I could really say that would happen, except for maybe someone with endometriosis where you want to suppress that endometrium, but that's not really the birth control pill, although people would say if you go on the pill, it could suppress symptoms from endometriosis. That's what people did in old days. That's the low technology approach. But the reality is,
What about Dr. Deckhoff? What do you think about giving somebody estrace and Provera in combination rather than the combined birth control?
I was going to say, Dr. Kiltz has strong feelings about that.
yeah.
Because it's essentially the same thing, but
Well,
some minor differences. Sure, it's not natural estrogen.
you could go.
I am a little biased against the birth control pill, and I believe that the estrase Provera or some progesterone, but prometrium is another one, but estrase Provera, I think has less side effects theoretically, and I think psychologically, the birth control pill is counter to the philosophy of helping you have that
Get
baby.
pregnant,
So
right.
I like the idea of suppression, and then I like the idea of withdrawal and a menstrual period if that's what we're trying. But technically, if you're doing a frozen cycle, you don't have to have a birth, and you don't have to have a menstrual cycle at all. I think the estrogen progesterone has a little bit of a priming effect to help open up.
And they're not exactly the same, right? So birth control has synthetic estrogen in it, and it may be a little too harsh to use in the situation. Estrase will be a little milder to the body.
Yeah, I think that's a good point. The synthetic part, and there may be a little higher risk of blood clots and stroke with the birth control pill, although they're small. But when we have estrase and Provera, it's such an easy thing to prime everybody with it for those special events, timing, and then you withdraw them at their period if you're planning a fresh transfer. But if it's a freeze-all, which we recommend overall, then you just stay on it, start your stimulation, and then you stay on the Provera, which will help reduce the risk of ovulation.
I think these are all good points. One thing I have to say is sometimes, as was pointed out, the birth control pill is more potent. Norepinephrine acetate, which is in the birth control pill, ethinyl estradiol, which is in the birth control pill, is more potent than estrase or Provera. And therefore, sometimes it depends why you're putting these women on the on hormones. If you really want, if they have a very thick lining, if you want to control them for scheduling reasons, there is a potential chance for the patient to break through estrase Provera as opposed to birth control pills because it's less harsh. So again, there's really no perfect answer for this. I think it depends on the individual situation.
But I think there's the worry out there and a lot of talk about the birth control pill is more suppressive. Now, I don't know that I believe that. So that's why I think the psychology
And
of
when you
it.
say suppressive, tell folks what you mean by that.
Well, the thought is for some people that when they start their stimulation and they don't respond, they don't make aids enough, that the birth control pill may be part of the reason why it didn't work that way. Now, I don't know if I believe that, but I think that's part of the.
I think it would probably just attenuate the cycle a little longer, right? Because they're eventually going to respond, but they might take more days injections.
Right, which is more
Well,
expensive.
very costly.
You know, so.
You know, since we're on the subject here, I want to say, you know, folks in birth control pills, people think, well, yeah, like Dr. Kilt said, birth control pills, but I'm trying to get pregnant. Why do I want to be on birth control pills? And sometimes what will happen here, whether it's birth control or estrogen and progesterone, as we're approaching the time that we're going to be starting a cycle, sometimes in the CNY system, we will put you on a few days of some estrogen and progesterone before you actually start your stimulation. And we do that so that we can make sure that the timing all lines up properly and that we can best serve you, you know, from a calendar standpoint. But there are many practices. In fact, I would venture to say most other practices batch their cycles. How do they do that and why do they do that?
Well, I have experience with a past program I've worked with that somewhat is batch, and they would use a birth control pill, and they would stop it all on a particular day. For example, they might stop it on a Thursday or Friday and start the stimulation on a Monday. That way, the retrievals would fall during the week, not during the weekend. Again, that's why people program cycles. They're trying to make things predictable for different reasons. It could be staffing reasons, it could be a lot of reasons. So I don't know if that answered the question, but people could use more moments to help scheduling when it gets to the period when they start the stimulation.
All right. I want to take a second just to give a couple of shout outs here. I saw Brandis Montez, who is our wonderful nurse practitioner from CNY Fertility in Colorado, was on, and I saw in the beginning a couple of people said they were pregnant and they had their babies already because of Brandis's transfers. So hi to Brandis, thank you, and strong work there. Another hello to Leighton Young, I see, who is one of our wonderful nurses at CNY Fertility Colorado. Thank you both for being here. Hi to Zinni, hi to Angela, and to Susanna now. Susanna asked, AMH is 0.46, and I had an HSG and a San Marzano that is normal. So what would be your approach to type of transfer to do with only 2 deployed embryos?
Well, first of all, is it type of transfer or type of protocol?
Protocol.
What's your difference?
We're talking about medicated.
They're different, but there's different protocols. I just want to clarify.
I think she means natural.
So the first thing I would say is if the patient has regular periods and she hasn't done a frozen transfer before and she has a PGT test of normal embryo, I would probably encourage her to put 1 embryo in for the first cycle. Natural. If the patient has regular ovulatory cycles, she has an option to do a regular natural cycle. She can do a complete natural cycle modified by giving progesterone supplementation. That's what we generally do at CNY. There are people who don't like to take any hormones. They could do a natural, but that might be a little risky. I would support giving progesterone supplementation with a natural modified cycle. That makes sense. The alternative is the patient is the type that's a travel person and she travel and traveling is hard and monitoring. She's worried about when she's gonna ovulate. It's gonna take hard time to get to where she has to get to. She may not want to do a natural cycle. She might want to have more control over her cycle, be on hormones. That way she doesn't have to be stressed about getting to her destination for her transfer. So again, it's not a perfect answer for everybody. But I think those are two good answers.
So in other words, I don't think there's a medical answer to that question.
It depends on some parameters, like if she doesn't build a good lining, then,
Assuming all
You know,
things equal,
It sounds very encouraging for this patient, and I would be optimistic that hopefully because of what she has gone through, she has a normal tested embryo, hopefully she can get pregnant with her first attempt with the natural ovulatory cycle.
No, but here's a 37-year young woman with a lower, but her AMH is still at a reasonable level, could be a little better, but she's got these two normal embryos. And so we always have to look at, she has regular cycles. Why is she not getting pregnant? And so that's why the inflammatory evaluation of the pelvis before transfer, I think, is one of the important things to do. Do we do an endometrial biopsy looking for inflammation? And you know, whether or not we know about the receptiva yet and whether or not it's marker good or not, it may be warranted, or a laparoscopy, hysteroscopy, and or the 30 days of the antimicrobial and some nutritional changes to get her ready for that transfer. Because if we do the transfer, it doesn't work, and a second transfer doesn't work, whether it's medicated or natural or letrozole, we haven't answered the question, could there be some inflammation of endometriosis, endometritis that we're missing? And why wait for failures when we can at least look in at ways of mitigating that ahead of time?
so what you're advocating for is to be a little more aggressive on the workup, rather than just doing a saline sonogram and saying that, okay, it looks clean, let's just transfer. So,
Dr. Newhouser is going to
Doctor,
say
come
goodbye.
for a second, come here for a second. I want you to meet one other member of our team who is actually just pulling out of the room here, but step right in so that folks can see your face. This is Dr. Werner Newhouser, who lives in Boston. Dr. Newhouser is a very distinguished member of our team. We're very lucky to have him. He works sometimes in Albany, but he spends much of his time doing research at Beth Israel Deaconess Hospital in Boston on the subject of
Stem cell biology.
stem cell biology, which is really fascinating stuff. And we won't make him stay because he obviously.
be late for the first meeting.
Yeah, right. Because the lab is calling him, but I wanted you to know who he was because you may run across his name there. Hey, it's a good segue to really kind of a tragic or sad story from Liz Fisher on Facebook, who radioed in to us here. Liz had a transfer, got pregnant, and sadly miscarried at about 6.5 weeks. She's wondering, and we know that in most cases, miscarriages are a result of an embryo issue, but and even in a tested embryo.
But I think, and I'm just going to differ a little bit. It's inflammation. And inflammation damages the endometrial lining and it damages the embryo. And so we put a lot of normal embryos in uterus and people don't get pregnant. So is a failed implantation any different than a miscarriage? It's something that's preventing the embryo from either implanting or it's rejecting it early. So I find that what's our delivery rate of a PGT normal embryo? It's in the 60%. So that means 40% to 70%, but a significant number aren't making it. Now, there could be other abnormalities with the embryo, but it still comes down to intra-abdominal pelvic inflammation.
Well, so then to Liz's point, what would you do differently in another transfer?
Well, I think that's where you have to look more at the evaluation for inflammation, endometrial biopsy, and analysis receptiva, laparoscopy, hysteroscopy, maybe a good parameter. It may be empiric treatment for endometriosis, endometritis, for sure. And then I think the other half is maybe we should look more at the immune treatments And I personally don't think immune 1 or 2 belongs in the IVF world at all. We should be doing at least immune 3 or 4, because if you're infertile, it's almost certainly inflammation is the cause, and we should be thinking a little more aggressively, because people spend a lot of time and money and energy and emotions on this. We, I think, are leaders at this, even though most people don't believe in this. It seems like the most important thing. So that's my general.
Sorry, Kill, so we would actually bypass immune one. What you're saying for most patients.
Look at immune 1, I think doesn't belong on our IUI or IVF parameters. Maybe immune 2 for IUI, but immune 3, because the aspirin, prednisone, Lovenox, Prograf, and lipids are kind of really inexpensive in general. They're not expensive, and so I just saw a normal embryo didn't make it, and someone who had previous miscarriages and or failed it or not getting pregnant, it's automatically signals inflammation. And we know that inflammation is the cause of all disease. And I think that's what we talk about a lot. And so that's why I generally recommend at least a 3, if not a 4. The problem with the 4 is that IVIG are more expensive. If it were less expensive, I think
Everybody be on it,
more
yes.
significant. So we really should offer that maybe even earlier, because we don't know how much money or what resources are, but it may be. The problem is, but like the science, the science today at the meetings, did it say that ERA and Sativa were good tests or still questionable?
ERA, my understanding is people are doing better without an ERA than with an ERA. That's what I have heard several times.
Or it's just as well. Anyway.
Yeah, so it's hard for me, I would not encourage a patient to do an ERA unless they've done a lot of treatments, things haven't worked, and they want answers to things that have not been tested.
But is there harm to do the ERA? Is there not economic?
It's
But not economic. So our challenge is we bring our scientific biases. But the one thing I believe is that ERA endometrial biopsy may be the benefit, if there's a benefit at all. But
Because of scratch.
because of the scratch procedure, which I think we're not talking enough about, but that's why I think hysteroscopy, endometrial biopsy should be something we'd be offering on more people, because you get a look inside, you maybe see a small polyp or 2 that you could remove, you do a gentle curetting, gentle, and maybe we should talk about platelet-rich plasma intrauterine in more patients to also reduce inflammation.
Yeah, I think that that's not a bad approach, but the scratch, we do offer that at CMY, do we not? Just
We do.
Clarify that.
We do, but because I know myself, I'm not talking enough about it and offering it enough. And so I just want us to sort of, what's that list? And if you look at the family building guide, there's a list of everything you could potentially do. And it's maybe something that we don't talk about early enough, because we don't want you to wait for failures. We want to bring all these things to the beginning of your evaluation treatment option, so that you can make a decision of whether I just want to try a little bit and then do these things.
So I mean, to Susanna's answer, her question, the scratch might be something we would consider. That we could bring her in on cycle day 21 to 28.
Right.
I use the scratch as well. It's kind of a,
Or with a retrieval, we do a hysteroscopy biopsy, which essentially gives us a good information. And at the time of retrieval, it's very good because you're there asleep. If you're going to do a freeze-all, and then you're ready for a frozen thawed transfer the next cycle. And sometimes we might even think about empirically treating you with antibiotics for 2 weeks, a little more aggressive, because to cure like Lyme disease and H. pylori takes up to 4 to 6 weeks.
Let me throw this question out because it's a good one. This looks like it comes from Lacey Over Them, and it says, I was successful in my first transfer, already thinking about my next one. How do you feel about transferring 1 euploid and 1 mosaic?
Well, first of all, is it low-level mosaic or high-level mosaic?
Just let's say it's low level.
And how young is this patient?
Didn't say.
Okay, well, the guidelines,
The
again,
pregnancy rates of low level and high level are quite different.
well,
No, they're quite different.
so that's the, before I say anything, I just wanted to, I was fishing for more information. The guidelines are when someone has been pregnant before, especially if she received one embryo. If she has one normal embryo, I would not want to increase the chance of this patient having a miscarriage from a low level mosaic and jeopardizing the one normal embryo. So I would encourage the patient to put in one embryo based on the fact that she got pregnant before and she has one normal embryo. That's what I would probably do, but again, there's things I don't know.
Although mosaics, our numbers, we looked at our mosaics, they're nearly the same as our normal embryos.
Right.
No, no, all mosaics, all mosaics.
Right.
And I was talking to, in our PGT, talking to other people about it, that the mosaic should probably be loaded, just,
They shouldn't have they shouldn't have a category anymore.
normal, just normal. And there's a lot of controversy about PGT results anyway. That's a big thing coming out right now. So I think that in general, we recommend one embryo, especially a normal blast. I personally think that we just don't, because even normal embryos, we've seen normal embryos miscarry and the tissue is reported as abnormal tissue. So it's just not black and white here, for sure. I agree with Dr. Ditkoff, our general recommendation would be one, but we do sometimes do two. And sometimes people would put a normal and an abnormal in, because sometimes we'll allow, we do that. But whether or not it increases the miscarriage rate or the failed implantation, I don't know the answer. What are your thoughts?
I think as Dr. Kill said earlier, our job is to inform the patient about our thoughts and our concerns about what might possibly happen. We can't tell the future. If we could, we would know exactly what to do. So what we do is we want you to be comfortable. So if you want to put in a normal and abnormal embryo after we are gentle and explain this as best as we can without trying to make an issue out of potentially no issue, if the patient wants us to put two embryos in, we will do it. If the patient is comfortable with trying to be more conservative for reasons that work for them, well, that might work for us, because in general, like we said, the guidelines are for one normal embryo. The guidelines are you put one embryo in. These are guidelines, not dictation. We are not regulators, we're educators.
But if you've had failure, putting in two, we've seen improved outcomes.
Definitely, for
And-
sure.
and that's no-
for sure.
Yeah, yeah.
But a patient also, as a prior child, may not want multiple pregnancies.
Well, then they wouldn't be asking for two. Right, so, yeah.
You think that that's what they're
You
asking?
set me up for that, you know that, don't you?
But to clarify, the guidelines recommend singleton transfer for most situations. And most doctors in the country, certainly doctors at CNY, we think that in general, that's the safest thing to do.
We want one
Just in
healthy
general.
baby in it.
Just in general, yeah, there's exceptions and we're willing to work with you, but.
Right. Well, this has been a really wonderful time. It's unusual that I get the opportunity to be in a room with such esteemed colleagues. And so thank you guys all very much for being here. Dr. Robert Kiltz from CNY Fertility, our owner and father. This is, grandfather. Dr. Edward Ditkoff from CNY Fertility in Albany, Dr. Eric Chang from CNY Fertility in Buffalo, and I'm Dr. Randy Fink from CNY Fertility in Colorado. As always, I like to end my programs by reminding you that this is not the story of your life. This is not your novel. This ain't your final print. This is one chapter. And what are we doing? We are here to rewrite it together. Every step forward with kindness, with love, and with hope, because tomorrow is a new day entirely. God bless. Thanks so much for being here.
We love you, everyone.
Good
God
night.
bless.
Thank you.
God bless my brothers.
Bye.
Bye.
Oh, you.